my topic on TAVR in extreme annuli, which is a case-based discussion. So we have a 72-year-old female who is with comorbidities, hypertension, hypothyroid with a BMI of 21, and she is a case of severe calcific aortic stenosis with mean gradient of 42, and the aortic valve area is 1 with indexed valve area came 0.55 centimeter square per meter square. The angiogram was normal with intermediate risk STS score, and the ECG showed some conduction abnormality with RPB of QRS 150 milliseconds. So the after heart team discussion planned for TAVR. So the CT TAVR protocol showed that the annulus area is 280 millimeter square, which is extra small annuli with a perimeter around 59. So the derived diameters are 19 millimeter. The LVOT is 20 millimeter, and the sinuses are also narrow, around 23 to 24 millimeter. STJ is 23 millimeter. And the coronary height, so the left coronary height is low, 8.3 millimeter with a borderline right coronary of 11 millimeter. And then femorals are of good size. So here we have a patient, 72-year-old with intermediate risk with multiple comorbidities and severe calcific aortic stenosis, extra small annuli of 280 millimeter square with perimeter of 15 and 9, and then a low coronary height of 9.3 millimeter with narrow sinuses 24 millimeter with existing conduction block. And then, so after heart team discussion planned for TAVR. So to consider which valve. So before that, what are the various lessons learned from patients, various meta-analysis of various studies from surgical studies of small annuli. These small annuli is associated with increased patient processes mismatch, and the PPM is a direct correlation of increased cardiovascular mortality and all-cause mortality. And then less PPM has been associated with less good coronary reserve, less LV mass regression, and better exercise tolerance and improved quality of life. And then PPM not only the heart outcomes, but also it's an independent predictor of valve degeneration. And this was data taken from a STS ACC TVT registry where the more than 62,000 TAVR was assessed. The incidence of severe PPM is 12%, and as per the 1-year mortality, the severe PPM has associated with 17.2%, which is significant compared with moderate PPM. So the incidence of small annuli in surgical valves is 22 to 44%. Whereas in TAVR valves with balloon expandable it is 31 to 36%, and with self-expandable valves is 21 to 22%. And then this was the recent trial published in NEGM, that is SMART trial, small annuli randomized to evaluate versus SAPIEN with small annulus with aortic annulus of less than 430 millimeter square. So the patients, 716 patients was randomized to self-expandable Medtronic platform Evolute Pro plus FX versus SAPIEN 3 and SAPIEN 3 Ultra. The co-primary outcome at 1 year in terms of mortality, stroke and heart failure and hospitalizations, there is a difference of 1.2% favoring towards self-expandable valve, but not much statistical significant. And the second co-primary endpoint in terms of bioprosthetic valve dysfunction and the mean gradients. So there is 8 millimeter less mean gradient with self-expandable valves, and the effective orifice area obtained with self-expandable valve is 0.5 centimeter square higher with self-expandable valve. And our patient had a left main 8.2 millimeter, so we need to consider a self-expandable valve that can be retrievable or a balloon expandable valve with large open cell and shorter frame. So the plan is to take a self-expandable valve, supraannular self-expandable valve, accurate neo, with upfront coronary protection with a guide extension catheter, with a wire and stent, and standard right femoral axis for valve and left femoral axis for coronary, and then right radial for aortogram. And then after crossing the valve, then we have done balloon with 18 millimeter. There was some sequestration of the left sinus, but coronary filling was there. So suspected coronary occlusion, so that we have protected with guide extension catheter and a wire with 4.518 stent, and then the accurate neo-2 valve was taken, and so the marker at the level of annulus, the valve is deployed, slowly releasing. So then after that, we have taken the final angio shoots. So the coronaries was filling well, then there is no occlusion and no ECG changes, no symptoms. So in patients with small HICC annulus, and they are very at risk of adverse hemodynamics and processes patient mismatch, and this associated with increased mortality, hospitalization, and heart valve durability. So the self-expandable supraannular valves offers a better hemodynamic performance without sacrificing clinical outcomes as per SMART trial. Hence the preferred valve in small annuli are self-expandable valve. And this accurate neo-2 valve, which has the upper crown that which caps the native leaflets away from the ostia and protects from coronary occlusion. The second case is a 77-year-old male, known COPD, diabetes, hypertension with BMI of 27. He presented with symptoms of heart failure, and echocardiography diagnosed to have LV dysfunction with ejection fraction of 36% with the calcific aortic stenosis with a mean gradient of 24 to 26. The aortic valve area is 1 centimeter square. Angiogram was normal and is a high risk STS score. So this was the mean gradient of 24 with ejection fraction of 36%. So here is a patient of low flow, low gradient aortic stenosis with ejection fraction of 36 with gradients of 24, and then we have subjected the patient for a stress echo. On stress echo, the gradients was increased from 24 to 45 millimeter of mean with peak of 60 millimeters of mercury, and the index valve area is 0.6 centimeter square. So there was increase in stroke volume, increase in the gradient. So the case of classical low flow, low gradient AS, and the patient can be benefited with TAVR. So that after that CT TAVR protocol was done. The annulus is extremely large annulus of area 816 with perimeter of 100. So the diameters derived are 32 millimeter. The LVOT is 34 millimeter, and it is a type 1 bicuspid with ICD at 4 millimeter and 8 millimeter 35. It is a flower type of bicuspid aortic valve with roomy sinuses of 40 millimeter and 39 millimeter, and the coronaries of good size. So the patient was planned to take a TAVR. So we have an extremely large annulus of 816 millimeter square with 100 millimeter of perimeter. So the risk of device embolization or migration and a high chance of paravalvular leak. Coming to the study data. So the TAVR versus extra large annuli, TAVR versus with standard annuli, it was found that there was no much difference in terms of 30-day mortality and mean transvalvular gradient, technical success or device success. There is slightly higher risk of moderate PVL in patients with extra large annuli, more than 680 millimeters square. And then the requirement of permanent pacemaker implantation also less with extra large annuli. So we have chosen, so as per valves available, we have 29 millimeter sapien which covers annuli of 680 millimeter square, and 34 millimeter Medtronic valve will cover up to 94 millimeter perimeter. So about our patient having around 816 millimeter square. So we have chosen extra large sizes availability of my valve, which is 32 millimeter. Then we have taken the case. So first the patient was pre-dilated with 24 millimeter balloon after obtaining access. So, and then 32 millimeter my valve with added 2 to 3 cc, making 33 millimeter, and then it was deployed under pacing around 200 with slowly deployed with pacing around 200, and the final result was good. So TAVR in large and extra large annulus is also a feasible option and providing similar device success and complications compared with regular sized annuli. Post-interventional pacemaker rates were lower, and there is little higher incidence of PVL with in extra large annuli patients, and 32 millimeter valve has had availability of large and extra large sizes in my valve, which covers up to 840 millimeter square of annular area. Thank you.